Okay, so my name is Victor Chong. Some of you probably heard me speak before. I am now have some of you probably know that I was in Oxford, and I just left Oxford, the clinic, about 3 years ago. But actually, I officially left my lab now a few days ago. So a really sad moment for me, that but I still got some Oxford pictures. And now I'm back to London in private practice. But today I'm going to talk to you a little bit about the new generation of laser and what are the differences, but touch on a little bit of principle very quickly, because some of the principle that you probably heard about it many, many times already. This is my financial disclosure. Leaving Oxford, I went to Boehringer Ingelheim, which is a company that you probably never heard of before. But then, just to advertising that we have opened the free IND, so we have 3 molecules in human in retina already. And we will probably be the most well-known retinal company under my directorship. I'm a consultant for Quantel, and Royal Free have received grant from Quantel, and I got a company called EURETINA Limited, which we make little devices that to cure your AMD and diabetic macular edema. Not quite there yet, but we will be one day that will sell you those. Okay, go back to the talk today. Basically, that we talk about why laser work. Now, it is very separate from why laser work for proliferative disease in PRP and why laser work in the macula. So I think it is important to separate those two things. For macula, the very beginning, when we're talking about diabetic macular edema, we say that we want to shoot at the red dot. And as you know, the red dot is the microaneurysm, and it almost makes sense. You shoot at something which is leaking, and then they stop leaking. So I think it was a very simple, logical thing to think about. And indeed, that's how laser was perceived to work. But as you know, that quite often, that what we think how things work does not turn out. And it's also by very clever clinician, rather than necessarily the scientists, to discover that things might be different. So what this first thing is that in the old days, that the laser machine is not as good as they had today. And the lenses that we use are not as good as today. And also patients still move, and just like as they are today. And you shoot the laser spot, and then sometimes you miss the red dot. And then sometimes we shoot the red dot again, and then you have problem, bigger scar. But some people were taught that, well, if you miss it, just keep going. And then it seems to still work. And then first thing starting the people observing more and then more and more begin taught, just don't bother, if you hit it nearby, it will be fine. But it will not be fine if you didn't want a direct coagulation, because direct coagulation, you need to hit and shoot at it. And similarly, ophthalmologists are surgeons in heart. When you got new toys come along, when the red laser come along, you want to try it. And again, the good thing about the red laser is that you can go full blood. And so you got a little bit of vicious hemorrhage, you can still do a PRP. And so that was why that it was fun to have a red laser in those days. But then, when people using the same laser for macular disease, it still work. Right? You're not supposed to work if you got direct coagulation, because if you're shooting the red dot, the shooting the microaneurysm, it should not work. Because you should go through the microaneurysm, because those are blood. So from those observations, we gradually coming to the term that we really think that we can just, really the RPE cell is what it matters. And then most of the people in Europe in the last probably 10 to 15 years, if not even 20 years, have been taught about doing this very gentle, light treatment. And Professor Bandela have been really advocated that, and we become almost the standard teaching in Europe at least. Not quite so much in the US, but certainly in Europe and Asia probably, also they're using this kind of light, gentle grid treatment. And which shown to be work as well. And the argument to us is that, well, light burn is probably better than heavy burn, but then what about that not have burn at all? I know surgeons like to see something when you do something, but then multiple concepts now that like in intravitreal injection, you don't see any scar anymore. When we did PDT at some point that you didn't see scar anymore. And so it's kind of gradually that we might not need to see something, but then something happened. And I think that concept is very, very important for micropulse laser treatment, because you don't see anything, but doesn't mean that nothing happened. And Peter Scanlon is one of my colleagues in Oxford, and he always told me that, well, micropulse laser is just like homeopathic laser. Well, I told him that, if you were Prince Charles who believed that homeopathic laser actually, homeopathic medicine actually worked, then yes, this is like homeopathic laser. But anyway, so the target is RPE cell. You want to attack the RPE cell. That is how all the laser work to a certain extent is to get to the RPE cell. And one of my ex-fellow now, the professor in diabetic retinopathy in Moorfield, wrote a paper on the concept that when you shoot at the laser, if you shoot and kill the RPE cell, you can't imagine those RPE cells will work. So there must be something else, because you can't kill something and then expect it to work. Right now, as I say, PRP is slightly different, so I'm not going to jump into that. Right? PRP, you probably need to kill some stuff. But the idea is when you kill some cell, the surrounding area, that those are activated but not killed. And then the idea is that we try to kill less, ideally kill none, and then we have the sublethal area to work. So going back to the thing is that some years ago, in fact, that the whole original concept of lighter means reducing the power. So what about reducing the power to you can't see it, right? So that is an attractive idea. And indeed, that is the idea for the TOPCon endpoint management. And Daniel Levinsky, obviously holding the patent for the Pascal laser, were looking at how that we can reducing the power. And this is a rabbit experiment. As you can see in different scope that even in a rabbit who doesn't move, on a pattern laser who should be always in focus, you still got some variation in the retina. And you can see here, but in general, that you have the energy too low, just right, and so on. So it actually work out in the rabbit that if you're using the 100% as the clearly visible, and then you can have kind of turn it down, and then you would have kind of less dead cell, but you had more activated cell. So that's how endpoint management come along, and then we were discussing the difference between endpoint management and power and micropulse. So the conventional versus endpoint management is quite simple. Conventional laser using around 50 micron or to 100 micron, about 100 milliseconds. Some people use 50 milliseconds. American quite often use 50 milliseconds. 100 milliseconds are more the usual for Europe. And the energy was kind of just visible, like the light protocol suggested by Professor Vandella many years ago. And endpoint management, because they come from the Pascal laser at that time, and then the spot size was 50 micron, and using a test spot of 20 milliseconds, and then you get to just visible. And I did ask that, what is so special about your endpoint management button on TOPCon, and basically saying that, what you actually do, because they told me that it's a very complex mathematical thing that they have calculated it. But my understanding of laser is can either reduce power or reduce duration. And indeed, that what my understanding is that, the endpoint management is just reduce the power and reduce the duration a little bit on both, and then you cut it to the power around the 25 to 30%. Now, obviously that I might be wrong, but you can see whether that you can just do it manually rather than using the endpoint management are showing the same thing. And Levinsky group also show that, the therapeutic window is very narrow. And that is why that they say that using endpoint management is very important because you need to get it just right. I think that is really also that they show in that. But you can see that even in the rabbit, that there is variation. So when the human who move, might be slightly even more difficult. So we talk about micropulse, we talk about subliminal laser, and I'm sorry that I forgot about that. We're not supposed to use the word micropulse in this particular symposium sponsored by Quantel. So I'm sorry that if you guys get sued, it's my fault. I've forgotten about it. And micropulse is registered for a trademark for EURETINA, and so we're not supposed to use it on any of the Quantel supported symposium. I do apologize on that. Although it's exactly the same thing, but again, but but we are always going to talk about subliminal. And if I accidentally say micropulse, I mean subliminal. So please forgive me on that. So The micropulse is just the pulses are giving on slowly, over in pulses mode, and so the energy can have a little bit of time of disperse before the next energy come along, and then we show that we'll be able to get more energy to the RPE cell and with less energy to the retina, and that's the real only differences. One of the key things that you need to remember if you not use micropulse before are converting is that to use subliminal laser, then you really need to use a lot more spot. You're using lower energy, but you need a lot more spot, and I think that's very important to remember that. And subliminal laser, there's no scarring. It's safer to do. The therapeutic window is much larger, so that's why that we can't even among the expert, we can't really agree what is the best protocol. There is some differences. And again, this is a Quantel symposium, but if you want to come to a micropulse courses next year, that we do run one, but unfortunately the one that we run this year was on Thursday already, is gone. But the differences are minor because the therapeutic window is quite large. And just like that, even conventional laser, you can use 100 millisecond, 200 millisecond, 50 millisecond, using different power, different spot size, different energy. So, but they all seem to work. So, but again, micropulse, because the therapeutic window is a bit wider, you have a different way of calculating the power. And I think that is something to remember. And again, if you are using the Quantel laser, then I would recommend you to use our recommendation, because that is from what we use the Quantel laser for. And in previous year, someone actually told me that, I'm using your protocol, but on a different company laser, and then it seems to cause problem. Well, that is why I'm sorry that I make a declaration that if you're going to use that particular protocol, but only on the Quantel laser, I can't guarantee what other laser does, and I think that's important as well. And again, obviously there's disadvantage is, new machine, and you can't see any change during procedure. Surgeon like to see something happen, so you need to get off your mindset that nothing happened, and you need to feel good about it, and so it does take a little bit longer as such. And this is the protocol we discussed, and obviously Quantel, we're more than happy to send you a copy. You don't need to take a photograph on it, if you really want to carry on, but we can, they will more than happy to give it to you, but don't use it on other laser. Right? That other laser, you maybe can modify from it, but don't use exactly the same thing. Because I think that at least one colleague that told me that when they were using another laser, it's not right. So, but I don't know what actually done, so don't know, right? 160 micron, 200 millisecond, 5% duty cycle, tested when just barely visible, and then you treat. So the way that I would see it is that any cautions is to using lower power than more power. So if you say that when you are doing the testing, you are say, this is say 1 millivolt or 1.2 millivolt, then let's go for 1,000 millivolt or 1,200 millivolt and go for the 1,000, right? So the lower is the one that you should aim for if you really can't tell between two levels when you are doing testing, because you really want to be just visible, right? And some other doctor will say that, they're using a slightly more visible and then divided by a third, which is fine too, right? Because it's the same thing to getting to the same result. And again, I can't divide it by 3 in my head, so I choose divided by half. So again, there's multiple way of doing it, just like that people set up the phaco machine differently. Doesn't mean that they're wrong. Just that there's slightly different way of doing it. And then the key is the dense treatment. You don't worry about overlapping, keep shooting, and do a little bit more spot, and then turn up that if you see a lot of scar afterwards, something's wrong. Then you need to make sure that you need to check out what went wrong. Either your setting is too high, but it's usually not you've done too many. It's usually your setting is too high, or you have forgotten to turn to the 5% duty cycle, or something the setup is wrong. And then obviously that if you've done a lot of you've done the treatment, it doesn't work at all. Well, either all of us are lying to you, or that you haven't done enough spot. So those are the two usual problems as such. Okay, so going back to the differences between subliminal laser and conventional endpoint management, as you in this paper show that even in the endpoint management, they still cause some scarring, but not visible when you're doing looking at the fundus, but you will see the scarring when you're doing OCT as such. But you don't see anything in the subliminal or micropulse. So that is a different, and you say that there was potentially subthreshold because the window is quite narrow, so you might have not enough energy, and subliminal that you solve that problem. And also that when you try to look at endpoint management and go ahead and find how many control trials that they have using endpoint management for at least diabetic macular edema. There's kind of one case series for CSR that I can find, but it could be wrong. It could be more publication since I last looked at it. But at least there's 200 publication on micropulse and multiple center, multiple group. And then I just want last few minutes to talk about the 2RT laser very, very quickly. It's slightly different. And then on the 2RT laser, obviously that they're now more focused on Jusen removal. And some of you do know that they did try DME before. And then DME doesn't work very well, but although there's a case series to show that they have some efficacy. So the difference is that it's a green laser. I don't think the color matter. And I did talk to a Chinese group at some point in the old days and say that, well, why should you use a yellow laser? Well, since we are yellow people, and it would be good to use a yellow laser. No, anyway. But the difference is that they use a very, very short duration, a 3 nanosecond duration. They target the melanosome, they have less collateral damage. And looking at some of the publication, the cartoon showed that they got this little star that the laser spot is bigger, but you should hit the individual cell. But then on the same publication that they're looking at when they're shooting at rabbits, or mice, doesn't seem to me there is any selection. It looked like it's a big hole in the middle with a lot of cell got killed. Now, obviously, this is from their publication, so it wasn't done by me. So I don't know whether that it might be just the laser do differently in mice compared with the human. And then they were saying that you would have no scarring. Well, again, depends on how you use the terminology. I think that we did argue over in one symposium, they call those RPE changes. Okay, right, they're RPE changes, so there's no scarring, but they got a lot of RPE changes, right? And it's visible, you can see it. So even at least the top core management, you can't see it, but in the 2RT, you can actually see it. And that's why that they move the spot further out, which is great, which is a great idea. So a bit further out. So again, you know, it's the RPE scarring is not going to cause any problem, you know, but it's good. And they also show that, although they're visible lesion, but there was no retinal sensitivity loss. And Professor Medina actually showed that, you know, when you do subliminal laser, that you know, in DME patient, the retinal sensitivity actually improved. So at least that is good that they don't cause any retinal sensitivity loss. But you need to know microperimetry, that you need to lose 2 decibel is quite hard. You know, so again, that's another thing that you need to think about. So finishing off, we'll say that I'm putting in all in millisecond. So subliminal is around 0.1 millisecond, and endpoint is about 10 probably, to be fair, although that is supposed to set the 20 and then press the button. And the 2RT is 0.000003. So again, that will give you a comparison, because I think I had sometimes struggled what is 3 nanosecond, but that is at least my understanding. Someone, if that is wrong, come and tell me. I think that is right. OCT changes, we never see anything in subliminal, but it's clearly visible endpoint management and 2RT. Autofluorescence imaging is not visible in subliminal, clearly visible in endpoint, and so far there's no published data, but I will assume that they got RPE changes, no scarring, then you will see it as well. Multiple randomized trial, more than 200 paper, more than 6-7 big group in the world have published the data that including randomized control trial, including one that we run from London and Columbia, publishing more than 10 years ago. And then we have just finishing recruitment on the phase 3 trial, including more than 400 patients in the UK. And so all these things are, you know, that either we're all lying to you, or if you are using your micropole, it's not working, then talk to your rep, and then something that might be wrong. And I really want to help you guys that, you know, you can come and talk to me as well to figure out what might have went wrong, you know, because either we're all lying, you know. Endpoint management, there's really nothing published that I know of as a control trial. They have some case series. 2RT had a very interesting control trial. They removed Jusen. They slowed down the AMD progression. However, that's in the post-hoc analysis. The primary endpoint has failed. 2RT laser only work if you do not have pseudoreticular Jusen. In fact, if you have pseudoreticular Jusen, you're way worse. And that is why when you add those two together, then there was actually no difference. So again, you can actually argue whether that is right or wrong, or whether you can make a claim or not. So if you are going for a drug development like in Boehringer Ingelheim for FDA, you will not get approval. But obviously laser doesn't need to get approval for that, for efficacy. So in summary, subliminal laser, there's a lot of publication, no visual acuity change, no visual change, improved retinal sensitivity. Endpoint management, very limited publication. You can see that, but it's much faster to do. Selective 2RT laser, there's some case series of efficacy, but there was some, there's some a good paper, I have to say, on AMD progression. But to understand that paper will take a little bit more time and a bit further more research. And indeed, that as I mentioned about the support that we got from Royal Free, for Royal Free, that we are starting another study on drusen removal for micropulse for subliminal laser. Thank you very much for your attention. And I have slightly overrun, but then I'm happy to take questions. Thank you very much.